Welcome to the Birmingham Medical News Doctors Talk podcast. I'm Steve Spencer, the founder of the Birmingham Medical News, and we are coming to you from the Kassouf and Company studios. Kassouf partners with us on this. They are an accounting firm that's been around almost 100 years. They do all matters, all forms of accounting, as well as wealth management, and they have a really active medical advice practice as well. And the Birmingham Medical News, we are a medical newspaper. We were started it 20 years ago. We essentially interview and write about interview Birmingham and actually North Alabama, Central Alabama doctors on all topics related to healthcare. We're a monthly newspaper. We also, and anybody who wants to sign up, you can email me. This is Steve at Birmingham Medical News, and we also have a digital list, which we just free of charge, mail out a digital copy. So, on to our podcast. Today's podcast is sponsored by Complete Health. If you're not familiar, Complete Health is a primary care practice based in Jacksonville. With actually offices. They've got clinics in the Daytona area, Denver, Virginia, and actually their biggest practices are in Birmingham, which may make sense to you because here in Birmingham, I'm actually a Complete Health patient, and I've had a great relationship with my doctor there. But I'll tell you a little bit about Complete Health. They've got a quality department that does all the important screenings, mammograms, colonoscopies, things like that. They also have a care management team that helps the sickest patients navigate the healthcare system. They've got a care navigators group that helps people when they're in the hospital see who they need to see. And again, they're not just a one-person provider. They actually have a care team. So when you're a Complete Health patient, there'll be folks in different areas of expertise who are going to help you. They've got great technology, and I can vouch for that. I use the patient portal. It's great. I recently had a complete, workup, and boom, all my results were there at the portal. So it was great. And they've got walk-in clinics for same-day patients. So our doctor today is Dr. John Farley. He is the medical director of Complete Health. And Dr. Farley is going to talk about value-based care, which is a really relatively new concept. And one thing I want to start with, Dr. Farley, is how was value-based care created and when?
Sure. No problem. So So I'm actually the chief medical officer for Complete Health, and we are based in Jacksonville, Florida. I practiced internal medicine in Birmingham for 28 years. I'm a fourth generation physician. We've been doing this since 1894 continuously. And one thing that struck me in my years of practice was that we were pretty much just focused on treating illness when it was there acutely and not really following patients outside of those acute visits. So we'd see a patient 3 or 4 times a year, and in between that, we really had no idea what was going on in their lives, right? Unless they reached out to us, we didn't know. And so with all the ongoing increases in expenses for healthcare, Medicare started looking at different ways to pay providers. And one of those ways is something through value-based care, where they basically pay us for outcomes rather than for volume. So value-based care is really more of a payment model where you get rewarded for taking great care of patients instead of just for individual visits, if that makes sense. So we actually have contracts with the insurance plans, including United Healthcare, Viva, Blue Cross Blue Shield of Alabama, and a couple others, Cigna and Humana, where we actually get paid a kind of a monthly fee to care for these patients. And then want to be available to them 24/7, 365. So when patients come to see us, we're not just seeing them for their high blood pressure and then giving them medicine and saying, hey, we'll see you back in 6 months. We're actually following up with them. We're checking with them. We're engaging with them, whether we do it at home, whether we go visit them, whether we call them over the phone, whether we do telehealth visits. But so it's really a kind of a different model. And we focus on getting patients seen in the timely manner with value-based care rather than, hey, my next available appointments 3 months from now. It's more like we want to get you seen quickly. And as you alluded to, we have walk-in clinics and we have urgent care. We have two urgent care clinics in Birmingham alone and several walk-in clinics. And so we want to be available to our patients, and we wrap a care team with value-based care around our providers. We have about 120 providers in Birmingham, and so that care team's consisted of care coordination people. We have a diabetes program. We have a palliative care program, which is run by our nurse practitioners and our RNs. And we have what we call our care coordination department. We have a transitional care department that follows patients after they get out of the hospital. And then we actually have inpatient navigators that do follow the patients in the hospital for us. And that's all coordinated by one of our medical directors who is kind of air traffic control, keeping an eye on what's going on with all our hospital patients. So kind of a quick summary of what we do, but it's kind of, I think, a much better care model than the fee-for-service transactional model where you see a patient, send them a bill, and then have no idea what's going on in their lives until you see them back, whether they come back in 3 months, 6 months, or 2 years later. So it's mainly focused right now on Medicare because that's the one they're the ones that are making this payment model change. And the CMS has stated, at least under the previous administration, that by 2030 they want most Medicare patients to be in some type of value-based care model, whether that's a accountable care organization or full risk contracts or just different types of models out there. What's going to happen with the new administration, we're not 100% sure, but I think there's still going to be a push towards the value-based care world. So.
And what are the key tenets of value-based care?
Yeah, the key tenants are, obviously, get the contracts with the insurance plans, so they're sharing risk with you, and then, get to know your patients really well. So we use a lot of technology to risk stratify our patients. We use this thing called the ACG Hopkins model. We plug in information from our patients. We take we plug in information from the payers. We get files from the payers that has all this information on them, plus what we have in our EMR. And then basically we're able to produce a list of who our patients are that are most likely going to need additional services, whether that's palliative care, hospice, or just stronger care coordination. So, it's the old 80-20 rule, right? About 20% of our
Mhm.
patients need the most services, the other 80% don't need as many services. So we identify those services. We use technology, or as I say, science, and we kind of figure out who needs to be followed and who doesn't. And then we enroll them in these programs, and we follow them closely. And that's a key tenet: is know thy patient, wrap thy patient into your practice, get to really
Mhm.
put additional services on them, and be available for them. One of our mottos is is call us first. So we actually have a whole separate call us first number that patients that are in our value-based care, these aren't all of our
Mhm.
patients, just our value-based care patients have a separate kind of 888 number they can call if they're having problems 24/7, and we can try to address them because we don't want patients to go to the hospital and we don't want patients to go to the ER. We want to keep them healthy and at home because, bad things happen in hospitals, that we like to avoid, like infections and things like that. And our goal is to be proactive in our care, engage our patients early in their illness, and do all the preventive services as you mentioned earlier. Make sure they're current on their colonoscopies and mammograms and those types of things. And then when they do have a problem, be able to get them seen in our office quickly. Because the longer you wait, the sicker you get. And by the time you've waited 4 or 5 days for an appointment, you might be in the ICU by the time you get seen. So.
And value-based care, it seems to me, I just not knowing exactly, it seems to me like, what does it go back about 6, 7, 8 years?
I think it all kind of started with the MIPS and macro kind of stuff back, when they were trying to
Mhm.
look at different payment models, they were going to adjust it based on some of the outcome kind of data. But
Okay.
really, the value-based care has been really pushed in the last, yeah, 6 to 8 years. And it's been
Mhm.
driven a lot by Medicare Advantage plans who,
Okay.
they get paid by the Medicare and then they want to contract with us to take care of the patients.
Mhm.
So then we do an agreement with them where we say, okay, we're going to take full risk for these patients, meaning we're responsible for all of their costs. And so we're highly motivated to keep our patients healthy because if they get sick, that's on us.
Right.
Um,
You're
but
taking the
but it's
risk,
not
basically.
but it's not a perverse incentive for us to not spend money on patients. The incentive is
Yeah.
to spend more money on the right patients and focus on the primary care side of it, so they
Yeah.
don't ever need to have all the procedures done. That we try to head that off. Let's get their cholesterol under control and let's get their weight down and let's keep them from needing to have a bypass surgery. So.
And so I assume your practices obviously were all originally fee based. Uh, what were some of the challenges in moving from fee-based to value-based care?
Yeah, I think the big challenges are particularly for our providers, and I was in the same boat.
Mm-hmm.
I stopped practicing a few years ago, and I'm a full-time executive now. But I
Mm-hmm.
think for our providers, it's that spend more time with patients, slow down a little bit,
Mm-hmm.
try to check all the boxes for prevention and quality at these visits, and
Mm-hmm.
and kind of I call it get off that treadmill.
Mm-hmm.
Because one of the things that really appealed to me about value-based care, and one of the reasons I joined Complete Health in 2019 was I was, probably mid 50s. I was like, I was getting burned out. I mean, I was having to see more and more patients. My patients were getting sicker and sicker, but I didn't feel like I was really spending the time I wanted to spend with them and be able to address all the issues at each visit because I had a full schedule every day. And that's the way my life was set up. And that's the way most primary care doctors' lives are set up. So one of the challenges for our providers is to learn to slow down a little bit, spend more time with patients, discuss end of life planning, discuss all the different things that you usually don't have time to do during a typical visit. And so I think it's a really good model, and I've really enjoyed it. So
Well, okay, so if since your doctors are trying to spend more time with each patient, does that mean your doctors are seeing fewer patients in a
so
typical day?
typically they are seeing fewer patients and spending
Okay.
more time with them, but they're actually making more money, believe it or not, because we, as part of the value-based care world, is if we do have what we call shared savings, we share that money with our providers. So basically, that's the money they get for outcomes. So if they do a really good job of keeping their patients out of the hospital, out of the ER, instead of saying at 4 o'clock on a Friday afternoon when they get a call saying, "Oh, just go to the ER," they say, "Okay, we'll squeeze you in at 4:15," or we have these 5 walk-in clinics, we have these 2 urgent care clinics in the Metro Birmingham area that you can go to and avoid a $800 ER visit or a $2,000 ER visit. They can be seen for $100 that. But again, I always emphasize the only way to be successful in value-based care is to provide better care to patients, not less care. Because some people, you hear the word value and you think cheap, right? And I think another way to look at it is kind of like concierge medicine. There's been all these concierge medicine practices where people pay to have a doctor that's available for them 24/7. So we're basically providing that to our Medicare patients. It's not for commercial patients yet, although we have a meeting next week with one of the big insurance plans in Alabama that wants to talk about, trying that kind of program on commercial patients as well. But so we basically provide concierge type medicine to Medicare patients, but they don't have to pay a $1,500 or $2,000 fee to see us for that. So,
Yeah.
um,
Um, interesting. And so you mentioned you're going to see a big insurer next week. Have the insurers been slow to
no, they've actually Blue Cross Blue Shield of Alabama. We actually did their first risk program with Blue Advantage, their PPO. They'd never done a risk contract. We entered into that last year, so we're more than a year into it. It's gone really well. Hopefully they're happy with it. We're happy with it. The patients are certainly happy with it as well. And so, yeah, no, I think it's good. I mean, the insurance companies, they would like to pass off as much risk as they can, right? And that's why it's really important that we as an organization at Complete Health know these patients really well so we can kind of put resources where they need to go and be able to, like head off illnesses. And, one of the things we do that's really, I think is really neat is if you have any of these 36 conditions, which are called ambulatory care sensitive conditions that should never be admitted to the hospital. If we see those patients in the office, we call them the next day to say, "Hey, we noticed you saw Dr. Smith for your pneumonia yesterday. We just calling to make sure you got your medications, make sure you're feeling better. Do we need to see you back in the office again?" And, so again, proactively engaging with our patients is what we do, and we like to say we hyper engage with them. So
so since you're doing all the screenings, you're hopefully heading off a big disease. Again, the idea is to keep patients healthy, which is the
right,
right thing to do, but also makes it profitable. And so you and not and I understand completely that you're not
yeah,
being cheap. You want to keep. You've got to. As a doctor, I'm sure you always had an incentive to keep people,
right. Oh,
patients
absolutely, yeah.
healthy.
And
But now
everyone
it
wants to do that,
aligns
right,
with how you're
right.
paid too.
Right.
You
Right.
know.
Right. Exactly. That we were, I like to think we were a victim of the payment model, right?
Yeah.
So, so like, for instance, when I started practicing, I had a pretty good reputation. I had tons of patients that came to see me and they'd all refer their friends to me, but I didn't get paid any extra for being for doing the quality stuff or any of that stuff initially, right? And so the only way I could make more money was to see more and more patients. And so the very thing that makes you good at the beginning destroys you in the end, because by then you're seeing 40 people a day. You don't have time to spend with them, and so in this model, it's the opposite of that, right? Let's make sure we're addressing everything with these patients. It's just a better model, and I think it's going to help with provider burnout, and that type of stuff, because you're able to have that time, be able to spend that time, and you get rewarded for outcomes as opposed to getting rewarded for volume, so that makes good
Eight
sense.
hours in addition to the notes you've got to take, the paperwork. That's got to be. I can only imagine. You were so had to be so time constrained.
Oh, absolutely. I mean, I used to get up at 5 every morning and look at all the
Mm,
labs and notes from the day before. In fact, your
mm,
doctor at Complete Health is probably doing something similar and sending
mm,
you those emails at 6 in
mm.
the morning from your day before, so you get all your results back. But
Yeah.
yeah, no, but again, the more we engage with our patients, the better their outcomes are, because the more they feel they can trust us, the more they know they can get in to see us. I used to see patients all the time that would come in and see me and they were really sick, and I go, "Why didn't you come see me a week ago?" And they said, "Well, I went to an urgent care clinic because I knew you were too busy to see me." And the fact of the matter was, a lot of times I was too busy to see them, but I wasn't getting rewarded for keeping them out of the hospital, the ER. It didn't cost me anything to say, "Well, just go to the ER," or just whatever. Let me just admit you to the hospital. Now it's kind of like, I think it's probably worth my extra time to stick around for 15 more minutes while they come and see me, and and do that. So.
Well, is there anything you can add about value care, based care? Do you see any big changes on the horizon with that, or how do you view the future of it?
Yeah, I mean, I think it's going to continue to grow. I think that with the percentage of our GDP that we're spending on healthcare and
Yeah.
in Medicare, and the cost of these new drugs and cancer drugs and all that kind of stuff, those are really going to put a dent in the Medicare, trust fund and all that, and
Mm-hmm.
that's not good.
Mm-hmm.
And so, like, if we can see a patient and diagnose them with a cancer, say at an earlier stage, where maybe they don't need the $50,000, $100,000 chemotherapy, they can be treated with a surgical procedure and get a cheaper round of chemotherapy because we caught the disease earlier. Those are the kind of things that we'd like to see. If we can get people's weight down and get their diabetes going to remission because they lost weight and they're exercising, then they're not going to end up with an amputation, and they're not going to end up with a stent in their heart artery or bypass surgery. So all those things I think are important, and I think the government, the CMS government folks are going to look at that and go, yeah, we want to continue to encourage the movement towards value-based care. Yeah.
Okay.
And so if a patient can't get to a complete health because you're not in their market, how do they know if their doctor is providing value-based care? Is this just a question you ask a physician or?
Yeah. It's typically going to be Medicare patients. It's typically going to be patients that are on like a United Healthcare plan or a Cigna plan or a Humana plan. But there are these accountable care organizations that you may just still have a traditional Medicare card, but you might actually be in an accountable care organization, and you may not know you're in that accountable care. You should get something in the mail every year from your practice saying, "Hey, you're in this organization." But and those accountable care organizations are similar. They encourage us to keep people out of the hospital. They encourage us to keep people healthy, and they reward for that. And it just makes so much sense to you get rewarded for outcomes and success rather than just volume, right? At least in my
Definitely.
mind, it does. So,
Yeah.
um,
Yeah. It's common sense, and I think we got so far off track. It just got worse and worse and worse in terms of pay for service, pay for and it became such a treadmill. It wasn't good
yeah.
for
Yeah.
anybody.
And I
Yeah.
think some, like, I mean, certainly, specialists, it's probably a little bit different.
Mm-hmm.
You want your cardiologist to be available. You want him to want to come see that patient at 3 in the morning. And so for them, fee for service may still make more sense. But certainly
Mm-hmm.
on the primary care side of things, I think the value-based care, does make sense. And we do actually partner very tightly with specialists. We
Mm-hmm.
reach into agreements with them. We're even now offering some shared savings that if we do a good job caring for this particular disease, then
Mm-hmm.
we'll share some of those savings with their doctors as well. So they also win
Oh, that's
from
good.
outcomes as well. And we're going to
Yeah.
probably see more of that in the future as well. So,
Okay. Well, I guess that basically, tells us what we need to know.
yeah,
Um, so we'll wrap it up, let you get back to work. But
sure.
thanks a lot for talking
Yeah.
with us.
Yeah, no problem. Enjoyed talking to you. And I've always liked reading your
Oh,
newspaper. So,
good, good.
yeah.
Thank you for listening to today's episode of the Ask the Doctor podcast, brought to you by the Birmingham Medical News and Kassouf & Company. Please make sure to like and subscribe, and make sure to tune in for our next installment. I'm Steve Spencer, and wish you and your loved ones a healthy journey until we see each other again.